So good morning, all the speakers, and uh, thank you for coming early in the morning. At least एक दूसरे को सुनने वाले कुछ तो लोग हैं. So I will be talking about. See, the aim of doing this instruction course is to help juniors who are coming into private practice and how do they begin their private practice. So I think I found it useful, but we all who are there in the panel are already accomplished private practitioners. So we'll hear it from them. So we all know the advantage of solo practice. We can practice the way we want to be, and we can give personalized private care, which is appreciated a lot by the patients. We also know the challenges, which are financial. You have to meet the statutory requirement once you're constructing your clinic. Admin work eats up a lot of time, and you have to stay up to date. And that's the reason these corporate chain of hospitals are taking over, and doctor colleagues of ours are going in for secured jobs and fixed salaries. But this was an interesting article which caught my attention, which reviewed the residents who were coming out of residency in ophthalmology. And once they were this was published in IGO, and they were interviewed, and almost 50% of these residents said that they either want to have their own practice or want to join their family practice. So despite the challenges of standalone practice, a good number of ophthalmologists are still opting for solo practice. Now, how and where does one begin? So we have to start from scratch. We have to lay down the SOPs, create a proper infrastructure, follow all the statutory requirement from the beginning, play smart and play safe, because we know that we are competing with these corporate hospitals. I think we all know that cataract still remains bread and butter, and two important aspects that we'll be discussing, Deepa will be talking about, and I'll be talking about, is how do we run a successful cataract practice. And it's very important to give your patients a good refractive outcome after cataract surgery, in which biometry is something which is of most importance. So this is what Deepa will be talking about, and then we all know that we have to give multifocality to all our patients, and how do we incorporate these premium lenses, this I will be speaking about. Now, once you begin your practice, how does one raise the standard of care and increase patient satisfaction? This can be done by rigorous accreditation process, which tells you how to follow the statutory requirements and all the things which are patient and the center centric. So Ashish will be talking about the NABH accreditation process. I think doctors are infamous for their handwriting, and there have been a lot of medication errors. So digital prescription is something which is now becoming common, and it increases patient satisfaction also. And along with this comes the advantage of that it's environmental friendly. You save yourself from litigation. The less room is required for record keeping if you go electronic, and there are a lot many benefits. So I think to go paperless is the way to go in future. I think all of you would agree that most of our patients are now opting for cashless facility. We have cashless everywhere facility also by many of the insurances companies. So again, how do we enroll with these insurance companies is again important, and we have to know how to negotiate and get best out of these companies. As doctors, I think we have always been focused on acquiring clinical skills, giving our best to our patients. So we were like horses focused totally on clinical work, and we've been relying for decades on word of mouth to get new patients. And whenever we talk about social media, especially somebody who's not very tech savvy may think that it's an extra work, and it may be simply not cut for us. But trust me, social media is like new yellow pages for doctors. And social media marketing is very, very powerful tool for building your brand, reaching new patients, and growing your practice. And this is what Dynamic Anchal will be talking about. So I think we'll begin with the first topic. Deepa, you can talk about how do we optimize the biometry. Thank you.
Thank you, ma'am. And can you please start the presentation? Working. Mics are not working. Yeah, so good morning, everyone. So I'll be talking about biometry and how to measure it right. So as we all know, there are three basic important investments that we have to make in our private setups. One is a good microscope, one is good phaco machines, and last but not the least is a good biometry machine. And now, as we all know, cataract surgery has evolved into a refractive cataract surgery with the advent of toric, trifocals, zeta of IOLs, patients demanding a spectacle-free life. And if we calculate the, axial length, any error in axial length of 1 millimeter would lead to a 3 diopter error in the refraction of patient. And similarly, 1 diopter of keratometry error could lead to a 1 diopter of a refractive error in the patient, which we simply cannot afford in these times. So this is how, over a period of time, the biometry journey is there. So it started from the ultrasound biometers, now coming to optical, and latest being the swept source OCT-based biometers. So coming to the ultrasound, there are two main important ultrasound-based biometers. One is contact applanation, and the other one is immersion. Contact is now, as we all know, it's almost obsolete because it involves the corneal compression and it can lead to erroneous measurements. Second one, which is an important one, is an immersion A scan. It minimizes technician variables, gives us more reproducible results, and this is how it is done. So we have to make adjustments we have to ensure good spikes and gain adjustment. And this is a video of our optometrist doing the biometry. So it's very comfortable for the patient as well as for us. And in normal cases, you can see the lens star reading is almost similar as immersion. It is exactly, the IL power is exactly same. But yes, we have to make various adjustments in various eyes, like staphylomatous eyes with macular lesions, dense cataract, silicone oils, etc. So the advantages of current optical biometers over conventional immersion A scans are: one, that it measures the axial length from the corneal vertex to the photoreceptor instead of ILM in A scan. It calculates, the ultrasound biometry calculates the anatomical axial length, whereas optical one calculates through the optical axis, which again is more reliable. So the accuracy of optical axial length is almost as near as and as good as 0.012 millimeters. In pseudophakic, phakic IOL eyes, the more accurate biometry can be done, and the kind of material used has less impact on axial length measurement. It is more precise in these in special eyes like myopic eyes and silicone oil filled eyes. So we have a host and we have a stack of options to choose from. So the optical biometers can be divided on the basis of the technology. First one is partial coherence interferometry based biometers. In this, Zeiss IOL Master 500 is the prototype, and it is based on the interferometry, and axial length is measured. Then came the OLCR based refractometer biometers. So the Lenstar 900, which we also have, is the prototype. So it permits a full A scan of the entire eye, including the retinal thickness measurement, which is possible. The other ones are Galili and Aladdin. So the key features of Lenstar is that it measures only when the patient fixates. It ensures the measurement is axial, and we get all these 9 measurements in one go with a great accuracy, of course. So this is a typical printout of a patient's eye with cataract with the IOL formulas. It has all the latest Barrett's Ostlund formulas, which help us in premium IOLs and others. So it also gives us angle kappa value. And the keratometry is dual zone keratometer. It is on the visual axis, and it has high resolution with 32 points. So the keratometry measurements are also very accurate. The main two disadvantages with this system is that it is not possible to do in dense cataracts and hazy media. So for at least 30 to 40% of the patients, we have to resort to ultrasound or immersion biometer. And also it lacks the total keratometries, which I'll be explaining later on in my talk. So the latest set of biometers are swept source OCT based. So Zeiss IOL Master 700 is the latest, and also Argus from Alcon. So these are the prototype. You can see how the IOL Master measures. In less than 45 seconds, the scan is taken. So we are done. So it makes the life easy, and workstation is less busier. So what are the new features in this? It has a B scan star pattern. It has 3-zone keratometry. White to white image is shown. And most important is the fixation check, where you acquire it when you see the fovea. So that helps in ensuring that yes, it is the correct scan. So you have to see the foveal pit. If it is not there, then it means the patient is not fixating properly. So we can also detect macular pathologies also with it. So with its superior cataract penetration, the densest and the most dense subcapsular cataracts as well, we are able to achieve a good biometry. So even in grade 4 cataracts, it is easily done. So with our own experience, after we took IL Master 700, almost 90 to 95% patients, they do not need immersion, while earlier the percentage was as low as only 50 to 60% cataracts we could do lens star. So these are all the measurements which are very easily and precisely given by this machine. So now coming to the total keratometry measurement principle. So basically we know that the posterior corneal curvature also contributes to the refraction of the eye. It is 1.32 diopter more steeper than the anterior, which can cause variable in the biometry, especially in patients with post refractive surgery eyes. So basically this overestimates the corneal power by 1 diopter for every 7 diopter of correction of refractive error. We have to use special formulas like Sharma's and Barres-Truquet or an Ascaris calculator for calculating biometry. So they have incorporated, this is a true K, which is a keratometry based on a, I'll just show it again, based on posterior corneal values and calibrated similarly. So this is a typical scan of the patients with cataract eye. You can see the keratometry values here, K1, K2, and TK1 and TK2 is the true K1 and true K2 power. So just a practical tip, if the patient has with the rule, this is actually very important in while we are putting toric IOLs. So patients who have with the rule astigmatism, TK would be lesser. So patient may not need toric. Whereas if the patient has against the rule astigmatism, TK would be more. So we should go more towards the toric side. Again, we can calculate angle alpha and kappa, and if their sum is more than 0.6, we should dissuade the patients for the multifocals. So I would like to conclude by saying that accurate IL power planning is as important as doing a good surgery. Patients should see clearly without glasses should be the aim of the surgery. And coming with IOL masters and newer technologies, the focus on toric lenses has increased, and why not? It should be there. And with with a lot of patients coming with post refractive surgery eyes, the IOLs they demand a spectacle free life. Immersion scan works for most of the cases, like almost more than 90% cases it works very well. So initially we must buy the optical biometers, and source OCT biometers are a must buy after an initial setup is complete, and after the immersion scan our finances are good, then we should plan and upgrade. Thank you.
Thank you, Deepa, for an extensive presentation. I think we can have quick questions because we have a lot of time. Deepa, I just wanted to know that you spoke about angle alpha and kappa. In how many of your multifocal patients do you always look at these values when you are choosing a multifocal or a EDOF lens?
We do see it, ma'am. If it is very high, if it is more than 0.6, 0.7, we'd like to dissuade the patient. But yes, there are studies which have proven now that, there was a study in Southeast Asia, and almost they had like 2,000 patients, and they say that it doesn't matter. There are a lot of other variables also. So it has to be taken in the patient profile, and a lot of other variables are there which need on the basis of which we implant multifocal IOL. So I would say that it is just one of the consideration. It is not a clear cut no.
Any of you have these the higher end that which sorry, I'm just forgetting the name, which measures the angle alpha actually by ray tracing, eye trace.
Eye trace. Because and
I just why I asked this question because I also have IL Master 700 and I have been looking at angle alpha. You measure that CWC and XY and
XY,
you
then
get those measurements. To my surprise, lot of patients. If I would say 100 patients, out of that almost 40 were having an angle alpha was more than 0.6. So I was wondering that all these
So
patients
it's
will be
not
rejecting from
yeah.
multifocal, but if you so then I did send couple of patients for eye trace and I found that in eye trace the angle was still within the zero
Within
point 0.6 range,
points.
so you could still implant. So with the IL master, though there's no published literature, but I feel with IL master 700 the threshold of putting a multifocal could be increased to 0.8 rather than 0.6, because उससे क्या होता है कि वो हम बहुत सारे rejections कर देते हैं
Yeah.
and then when you send those patients or they are coming from somewhere else, they say कि भी eligible है patient. तो that's what I have a personal, I mean, I no published data, but that's what I personally feel. And anything else that you wish to?
One more thing which always occurs to my mind. What is the till what time do we consider our biometry as valid? So many a time, let's say a patient had come an year back and gotten his biometry done, and then he wants to get his surgery now after, let's say, 6 and 9 months. So the patient is like, "Doc, sir, ये सारी जांच तो हो रखी है मेरी." So are we following a timeline? So I randomly decided that okay, if it is more than 3 months, three
Yeah,
months.
it's more than 3 months. We should repeat,
Cool. So
especially in toric IOLs.
yeah, it's there is no guideline for this.
So, yeah, yeah. That's what
But
we do.
surprisingly, I have found changes. So there was a
Especially,
patient. Yes.
yeah, especially if you're planning a toric IOL, then it's a must.
Exactly.
Very important.
Yeah.
Very important.
Yes. Yeah, just for your own psychological satisfaction, it is required. But yes, we have seen that more or less it doesn't change.
But
It's
with toric,
spherical.
I have
Yeah,
s-
with
I have
toric
seen,
IOLs,
they've seen
it
good
does.
changes.
It does. It
And
can.
is there any consensus on should we do the biometry if the pupils are dilated or non-dilated, or is that not?
Untouched. I mean, without any drop, single drop. First thing you do is
Untouched.
biometry.
Yes.
Yeah, but there's a problem
But that's
because
not possible.
that's
Or
not
yeah.
possible. Yes, that's not possible. So I raise this question. A lot of doctors are doing it totally complimentary. So the moment they know there's a
Yeah. So
cataract
even we do
patient,
it complimentary. with
but if you're
patients, yeah.
charging until unless you see and you advise, by the time some drops
But I
have been
think
put.
all of us end up doing it once the patient is dilated.
Correct.
But you actually find changes.
Yeah, definitely.
Yes.
If you're
Yeah.
planning for a multifocal, you must
There
repeat
are
it.
times when the patient has got a biometry done 6 months back.
6 months
and now
back, come on.
you had
Toric and
toric
non-toric.
and now there is no
Now
toric.
there is no
Exactly.
toric.
I
Yeah, it
had
has
it. The
happened a lot
IOL
of
was
times.
ordered, then
Yes.
the patient was unwell, and she came after 6 months, and the toricity was all
And
changed.
in fact, I would say that once I did a biometry, I mean, just last week only. At Lenstar, it was 1.8. We did it as in Zayo last Masters 7. It
There's
was
a
2.3.
there's a lot of
So that's a
variations.
problem
In
of
that
plenty.
cases, I
That's
have
a
always found
problem of
immersion as the
plenty.
best. If I'm comparing and I have to rely on one, then I'll rely on the immersion values.
But for toricity, there's a lot of change which happens. So whatever is the current one, I
Yeah,
focus
just-
on that. And toric
And it is very forgiving.
toric is a very
It's a very
forgiving.
forgiving.
Even if you
So
put 0.5 here and there, I mean, it doesn't.
it's
doesn't
that
Yes,
doesn't
the
matter
patient
that
comes out to
much.
be very happy.
The quality of vision is good.
So Achal, you wish to speak?
Yeah. So the next speaker.
So I think Achal has to go to the other hall. So we will have Achal speak about how does one market herself, and she has lot of awards. I think very dynamic surgeon who knows the game of social media marketing also very well. She practices in Chitranjan Park. So Achal, we can hear it from you.
I've moved to GK2. My hospital has shifted to GK2. Yes. So hi everyone. I am Dr. Anchal Gupta. I'm here to speak about is as a solo practitioner is marketing ourselves really important. Interestingly, I'm sitting with people who are all doing really fabulous. So I'm sure they all know the game of marketing much better than me, and I have things to learn from them. But I have a proper marketing team, and I have a allotted marketing day. So that's how we operate. That every Monday morning is the marketing morning, and that has worked very well. So we have dedicated days for our respective things, and then there's a Monday marketing morning. So I have decided marketing into several heads, and that makes it very very strategic and easy to distribute work among team members and to follow up how it um, goes on. So I'm also not just an eye hospital. I'm also an NGO which is working across 23 states of the country. So actually both of them are two separate entities, and both of them need actually taking care of two children at a time. And by God's grace, we have been able to very strategically manage it, and that has brought a lot of laurels and satisfaction together. So once we think about why we need to market ourselves, we got to understand first the potential. Whenever we are thinking of selling something, it's very important to understand that what is the potential. So we have to always keep in mind that our competitive landscape in India is 2 billion USD. So if we know why and how to sell what, we are eyeing at a mine of 2 billion USD. And I always tell everyone that if India has a population of 140 crore, then I have 280 crore patients. So that's a mindset with which we move forward. Cataract is almost 75% in our country over the age of 60 years. So yes, if the number of patients that we have is 240 crores, then two-thirds is, three-fourths is our market. So whenever you think of selling yourself, there are too many eye hospitals in the city, and many of them are very well equipped, and especially as a solo practitioner, you cannot compete yourself with an established chain. That's a demerit, but that can also be a merit, because in today's time, while the 5 stars are thralling, it's the boutique hotels are the one who are gaining more popularity, because people are looking forward to customized places which feel their own, and which have something unique to sell to. So whenever you want to market yourself, mentally figure out what is your unique selling point. Probably you were a gold medalist, probably you studied from abroad, probably you studied from best of the colleges, probably you were doing something very different from rest of the people, probably you had a machine which nobody else has. For Netram, the unique selling point which we have been marketing over the years is that we cater to those who can pay, those who can pay less, or those who cannot pay at all. So always have in your mind that what is that you are going to market, and always do a thorough homework about what is selling in the neighborhood, so that you have something unique to sell. Figure out in your mind what is your target audience. Your target audience in terms of demographic, um, what is the age bracket you are really looking for? Are you like really centering yourself to become a refractive surgeon? There's an entirely different way you will sell yourself. Are you are really looking yourself to sell to the premium cloud, or to the lower segment of the society? So you have to make it very clear in your mind from the very beginning, because this is something which I realized over the years, that we can't sail on all the boats together. Of course, the other small boats would come to a shore, but there would be a ship which you have finally decided to sail upon. Figure out your demographic area, what area you are going to cater. This has a lot of implications in how you are going to planning your marketing, your team division and everything. So it's extremely important that you choose upon a demographic area, at least to begin with. When you have a limited team, when the team grows, you can of course keep on adding more demographic areas, but that clarity of border marking is also very important in the mind. Now, the marketing channels are basically, I always tell my team, it's a 5 pronged heads that we highlight upon: digital marketing, word of mouth and referral marketing, community engagement, traditional marketing, and channel partners. So grossly, these are the 5 heads in which the marketing teams are divided, and hence the follow-ups are taken up. So when we come to digital marketing, the first and foremost thing for anybody who is a solo practitioner is to have a Google business profile, and this Google business profile should be verified. Just like the Insta and the Facebook have a blue tick, a Google business profile also needs to be 100% complete, and this needs a good research. So there are a lot of courses online which can help you how to have a proper business profile. I learned it an year back, and I realized that it was a really important skill that I learned. So almost being 12 years in practice, 11 years, the Google business profile was thriving just in Google reviews. But when we cracked that there are so many other small things that can be edited in the profile, and then finally we can have a verified badge that now the profile is 100% complete, that makes a huge difference on how your business is going to show up. The other important thing is obviously to have a website. A website should be something which is very, very dynamic. It can be on a React platform, so that you can have as much amount of data, and the loading time is not slow, and it should be a mobile friendly website. After having a website, it's very important to have a thorough SEO optimization. with market sensitive keywords, which the professionals are capable of doing. But don't just blindly rely on the professionals. You have to simultaneously have an understanding of what is it that is going on, so that you can have an edge with the professional, giving the terms which you understand are important. Once the website is SEO optimized, it is then the time to do a Google and a meta ad. Unless and until the website is SEO optimized, there is no point doing a Google and a meta ad. It is not going to take you anywhere. In today's time, meta ads are more relevant and more centric than the Google ads. And of course, we can have small online courses to understand the hook behind these meta ads, creating backlinks and creating bringing your website on questions which indirectly lead to your business. Having your YouTube videos and your Insta channel has, my daughter told me, so a lot of people tell me that, oh Anchal, we keep on seeing your videos, it's so nice, but honestly speaking, it drains and sucks the life out of me. So one fine day I just was like, dude, yeah, I'm not gonna do this. So my 10-year daughter tells me that, mom, in today's time, having a YouTube and an Insta channel is almost like having chairs in your chamber. So this is the kind of clarity a 10-year-old had. And then when she said this, so I was like, she's actually very, very right. She said the more the more followers you have is almost like as many chairs you have in your setup, and we can't undo it. So however cliche and uncool it might sound, and especially to generation like mine who is on the realm, I'm not the Gen Z, I'm not the oldie, I'm in between. I mostly mentally go to the side of the oldie, but still having your own YouTube channel where you are giving information, and having your Insta channel where you're giving your information is very important. If let's say it's not important for dragging the crowd, but your own patients will go back and retro check your authenticity. So after I started taking this sincerely, many of my patients came back and said to me that, doctor, you told us so and so thing, and we went back and saw your channel, and then we listened to it, and we really liked it, and we also shared with our relatives. So if it is not bringing you direct market, somewhere it is helping set up your authenticity and your sense of acceptance in your patient crowd. So we can't undo it, however it sucks your life and soul. Email and WhatsApp campaigns. So if you would have noticed that these days, even Times of India and Hindustan Times, the newspaper, are having full blown one page ad of how WhatsApp business has helped small businesses. So again, this is something which we were not well versed of, and until 5-6 years back, we probably did not even give that much attention to it. But WhatsApp business is the future. There would be a time when Insta and YouTube would probably become too down the line in terms of importance, but the way WhatsApp business is developing, it's high time that us solo practitioners or anybody who's keen on building up the practice should take online courses to understand the WhatsApp business, to understand how you can integrate your WhatsApp number in your own Google business profile. Yes, that is possible. Many a times patients, they don't feel like calling the clinic, but if you are able to integrate our WhatsApp business in the Google business profile, they can directly take an appointment, and the WhatsApp business will in itself send the reminders and feedbacks to the patient. So this was about digital marketing. About referral, it's a dirty market, but then it may not always be dirty. So the way we connect with our referral partners is we always give them a value add. We provide them learning courses. So it's not just a money transaction of percentage between me and my referral partners, but I always keep it as a knowledge exchange. The benefit of keeping it as a knowledge exchange is that if somebody else is coming and giving them a higher percentage than what I was giving, still the probability of them being loyal to me, the probability is because I was adding value to their life. So the set of channel partners are opticals, chemists, GP, RMPs, and of course the market perks and engagements. Community engagements have dedicated camps. Over the years, I've realized that having random camps here and there works no purpose. So figure out your target market area and continuously keep on doing camps in the same location if you really want the results to come back. So because that gives a sense of connection between the community and the organization, and that gives a better result. Of course, there are RWAs, social organizations like NGOs, and again, these camps should not be just an eye camp. They could be a sense of value add where you can give a coupon that the patient can come back later to the center. Then there are organized sector like insurance, LIC agent, Anganwadi workers, ASHA workers, eye hospitals outside the city, Ayurvedic hospital, alternative medicine institution, schools, universities, college, corporates, the list is endless, and we can have a proper network channel with them and have a team which continuously goes and nudges them and organizes them for them. Conventional marketing in terms of newspaper, print media, there are now online news app where we can free keep on putting, so they are not paid, and there are apps like Public where you can just keep on putting your own news. If you have purchased a new machine, if there's a shift on something, you can add and get yourself reached among the public. There are methods of foot marketing where individuals can go and meet people and tell them about the organization. Once you have decided to market, it's very important that your brand is very clear. What is the logo, what is the font, and how you are ultimately building a brand recognition. They could be auto ads, bus ad, metro ads, signages, hoardings. Once you have reached that, you have taken up to a level, it's very, very important that you ultimately start building a brand recognition so that people have a recall. The moment they see that logo or a signage somewhere, they immediately recall, oh, we saw a YouTube video of her saying so and so thing. Partnership and growth strategies with online aggregators like Prac, Pristine, Ayushman, CGHS Bharat, collaboration with insurance partners. They have their entire full network tying that up. Once you have decided, this is very important, digital should be having an allocation of 40%, referrals 30%, community outreach 10%, and traditional market 20%. Once you have decided your budget, always have a monthly review of the key performance indicators so that you can figure out that which of the 5 laterals is performing how much. Should we need to invest more? Should we need to invest less? And there should be a quarterly assessment. We might not take it very, very seriously, but if we start to take these steps seriously, it definitely brings a lot of difference in the way we are able to sell ourselves. This is my small team. This picture was taken 2 days before. Thank you so much.
Thank you, Achal, for a wonderful, wonderful talk. I think this is something which is we keep wondering that what to do and what not to do. So you have definitely given a lot of clarity to how to proceed. And just a quick question that what is panelists' take on the amount of budget that we allocate to marketing and
Once you attend these kind of talks, you become inspired. You go and you start doing things, and then the inertia sets in. You are saying, "I'm so busy, I don't have time to do that." So it's a very ongoing process, as she said, and it should be like doing a cataract. So if you are doing 10 cataracts, you should say that okay, 2 hours I have to dedicate to it, which is very, very difficult.
Yes. Yes.
Because you are so busy in your practice once the practice develops, and then the budget. Ma'am, then that is a very difficult question. But it,
Yes. Yes.
Dedicating 1 day for marketing. I think
No, so it's 2 hours on a Monday morning and 2 hours on a Thursday evening. So what I ultimately decided, what I ultimately realized is unless there's a block hour, so we call it block hour at Netram, and everybody knows that during these 2 hours, ma'am will be only with the team and nobody else. And for everything else, let's say I want to write a book. So I am writing a book simultaneously, which is another chapter. So for that also, we kept a block hour. So if you really want to be productive, see, definitely we are smart folks in the community, and that is why we have been able to reach where we are. But what stops us from reaching the highest realm is somehow we are not able to manage ourselves that perfectly. So block hour is a thing which really works a lot. You have to block yourself off everything, put your energy into it, and it gives the result 10 times more than what it would have otherwise possible chalta firta.
no, you're right. We have blocked our days for the conference. We can always block it for.
Right.
In fact, if we have a team, then one of us can block a day for that.
Yes. I was being modest. Yes, sir. So, sir, in the start of the presentation, I mentioned that I have an NGO, and the NGO is actually doing very well. It was awarded by the vice president of the country because I have not been able to put that in numbers, but our reach as an individual eye organization has become the largest in the country. The number of villages and states that I've been able to reach is actually it's the largest network. In my case, that has an entirely independent team which goes, meets the government organization. I also participate in government tenders, and I have won tenders against organizations like Vision Spring, Center for Sight, Mahavir Internationals. I won those government tenders. So yes, I have a social Saturday as well. So social Saturday, I sit with my CSR team and work with them. So how it helps me, that although that is Netramai Foundation and it is organizing community camps which are funded by my PSU partners and the government partners, but ultimately it is bringing brand value to Netramai Center, because the Netramai Center and I Foundation, although they are financially two different entities, but while I Foundation is growing up, it is bringing a lot of brand value and credibility to Netramai Center as an organization. And also lot of camps which I would have otherwise sponsored from the Netramai Center budget are being taken care by the foundation budget.
So that was great. So I think now Dr. Parul, who is our chief instructor, will be talking about how we can incorporate the premium IOLs in our practice. And as you know, there are two ways of growing the practice. One is to get more patients. Second is to get more value from the same patient, and also by giving more value to the patient. So that we can do by incorporating the so-called premium IOLs.
Thank you, Vinay. Thank you, Anchal, for an enlightening talk. I think in a solo practice, everybody comes with a mind frame. Everybody wants premium patients and want to do um, premium segment of lenses, premium surgeries. So I will be talking about that how and why do we need to incorporate these premium lenses in our practice. We all have seen evolution of surgical techniques from ICC, which I started in my residency days, to ECC, to phacoemulsification, and now flex. We also have seen a lot of advancements in technology in terms of peristaltic to venturi, and now we have active fluidics and active century. The lenses have advanced from rigid to foldables to multifocal lenses to torics, and now we have trifocal ERV and EDOF lenses on all these platforms. So the advances in surgical technique has made cataract surgery a refractive surgery, and the goal of refractive procedure is to successfully eliminate the need of prescription glasses with full correction. So why do we need to incorporate these premium lenses? Because I think all of you would agree, and I'm a hyperope myself, so I know presbyopia is pain. Now we all know that people are going for early retirement, so 60 is new 40 when people want to do a lot of different activities without any hassle of glasses. We are seeing a lot of cataract in younger population because of steroids, because of multiple lifestyle diseases. There has been explosion of these electronic devices in our life, and we want multifocality. We want to see things clearly at almost all distances. So I think all patients deserve multifocality, and if we are not offering these to our patients, I think we'll be left behind, because we all know that our competitors are offering these lenses. So when we talk about the patient wish list, it is kind of non-ending. Every single patient would love to have binocularity, multifocality, a full range of vision without any hassles of glare and halos. So it's not only just 6 by 6, but patients want N6 and continuum of vision also. And the options that we have to offer to our patients are the advanced monofocal lenses, the trifocal lenses, the EDOFs, the ERVs, and toric lenses on all these platforms. Now, why we hesitate in offering these lenses? There are a lot of reasons, but I think the most important reason is the dysphotopsia and glare and halos these lenses bring along. There is loss of contrast because the light distribution is happening to both distance and near segments, and that is why there's loss of contrast and patients are not too happy about it. And many a times when we tell that this is going to give 100%, actually 100% freedom is a false statement. It does not make you 100% spectacle free. There are times when you would need a spectacle aid to look or read clearly. The number two challenge is that any problems like you have dry eyes, you have residual cylinders, or you land up in refractive surprises. Now, all these areas you are going to have a much more amplified result if you are using these advanced trifocals or multifocal lenses. So, you have to be extra careful when you're dealing with such patients. Definitely, when patient is paying more out of their pocket, the post-operative chair time is more, and you have a lot of dissatisfied patients, and that's what you don't want, because you don't want your patient to be leaving your center, going to some other doctor and cribbing about the results, and unhappy patient about these lenses. And whenever these lenses which are so expensive, we are offering these lenses, so we have to be extra careful, and that is why we always feel that better है कि भाई दूसरा lens डाल दो, कौन इतनी headache लेगा post operative patient को देखने के लिए. So, how do we overcome hesitation and how do we start? We have to brace ourselves, we have to get the basics right, we have to choose wisely whenever we are starting, choose the right patient, the right intraocular lens calculation formulae, the right lens which is tailor made for that patient's need. So, first things first, at Deepa very nicely pointed out that we have to make our biometry as accurate as possible, and that is what we all should be doing. It has to be done on a pristine, untouched cornea. Good idea to have keratometry from two machines, the auto K and the optical biometers are good enough. As we discussed, that optical is ideal, but many a times when optical is not working fine, you have a dense cataract, immersion is good. I think contact is something which we can leave back, and immersion is something which is still very much acceptable. We have to look at the angle alpha and angle kappa. As a mandate, I do OCT for all my patients, which can detect sometimes a subtle epiretinal membrane or a VMT, which could be missed on a clinical examination, because last thing you would like, you've implanted a multifocal lens and patients comes back with a retinal problem. Now, we have a lot of patients who have ocular surface disorder, and again, patients with a multifocal lens with a dry eye can come back with khujli pani even though he's reading 6 by 6 and N6. So, to avoid these patients of MGD and ocular surface disorder, please give them a lot of hot compresses, lubricate them nicely. A very good idea to repeat biometry after you have tackled the dry eye, and you'll see a lot of differences in the measurement, especially if you are putting a toric intraocular lens. Now, once you have chosen the intraocular intraocular lens calculation formula, very, very important to choose your patient wisely, because what you need to know is to have a happy patient. Many a time the younger patients may be difficult to please. Again, when we talk about genders, males are difficult to please. You have to look whether you're dealing with a unilateral cataract or a bilateral cataract. Is it a myope patient or a hyperopes? Hyperopes are usually a safer bet. And again, look in depth into the occupation and the profession of the patient. Avoid a patient who's going to be fussy, who has retinal problems and has a bad ocular surface. Very important to prepare your patients preoperatively with a thorough discussion. Warn them about the contrast, glare, halos. Tell them and counsel them that they have to get operated both the eyes in a short gap for a better neuroadaptation. Tell them all the pros and cons. Tell them that they should not be comparing the two eyes, because that is where the problems come in. Do not overpromise and give them sufficient preoperative chair time so that you can avoid the post-operative chair time. And very importantly, discuss the cost factor, which has to be clarified pre-operatively. Now, many a times we have these enthusiastic counselors who go out of their way and use sentences like freedom from glasses, कि आपको चश्मा बिल्कुल नहीं लगेगा, बिल्कुल हट जाएगा. So you have to counsel your counselors that they have to use the words like reduce dependency on glasses and increase range of vision, rather than telling them that इससे चश्मा आपका बिल्कुल हट जाएगा. So once you have counseled the patient, you have done your biometry, you have to choose the appropriate formula. What I usually do is use the Barrett formula for my all calculations. Maybe going for a first myope or a e-metrope, depending on which lens you're opting for. Talk to the company guy, they'll guide you which lens, which power you have to opt for. If you're planning for an advanced monofocal, maybe a slight myopic shift in the second eye when you're planning, and definitely a very low threshold for toric lenses, especially you are going in for these advanced lenses. I think this is unsaid that you have to be proficient with your phaco, have a very good centered capsulorhexis, and remove all the viscoelastic from under the intraocular lens to prevent any kind of rotation with these premium lenses. So we'll quickly run through a few examples. Now, this was a 32 years old male, traumatic cataract, a sales representative who wanted a good range of vision. So I implanted a VVT EDOF lens, and patient is happy with 6 by 6 and N8 vision. On the other hand, this was a 45 years old home baker who had bilateral posterior subcapsular cataract, who did not drive. So I implanted a Synergy extended range of vision lens in this patient with 6 by 6 and N6 vision post-operatively. Now, this was an interesting patient, 67 years old, retired IS officer, whose brother had a trifocal lenses, was deeply disturbed by glare and halos. The lady loved to drive and wanted less dependency on glasses, so I implanted a pure C toric in one eye and a non-toric in the other eye, and patient is very happy, distance 6 by 6, drives comfortably, plays bridge without glasses, and reads with a little aid for any kind of book reading. Now, the last example, this was 68 years old female, retired school principal who loved to drive. So I implanted a trifocal lens. Initially, patient did complain of glare and halos, which settled over a 3 months period, and now she's very happy. Now, with these EDOF lenses, many a times you have patients whom you have operated many years back and you have implanted a monofocal lenses. Now, if they want a little better quality of lens and little better range of vision, I think EDOF lenses are something that you can implant in the other eye without too much compromise of the difference in the binocularity in that such a patient. So again, in this patient who had an accuracy of IQ in 2016, I implanted a Vivity lens, and patient is very happy using GPS without glasses, drives comfortably. These EDOF lenses, I just wanted to put in a word that these are very forgiving lenses, though there is loss of contrast, but they have very good defocus curve and a landing zone. But most importantly, we have to know when we have to say no to these premium lenses. Patients who have retinal problems, advanced glaucomas, large angle alpha and kappa, bad ocular surface, and a very, very fussy patient. So I think take home message would be that we should not be hesitating from implanting these lenses in our patients. We should be ready to take the plunge. Do a good biometry, a good surgery, choose your patients wisely, and choose your lens wisely. Thank you.
Thanks, Parul. Any questions? I think those are wonderful summarization. And the most important part, I think, is the proper counseling and setting the expectations of the patient. So that has been very. Just,
No, with the newer lenses, EDOF generally not. So I have a little higher threshold of putting these lenses because they have a central ring which is much more accommodating and a larger landing zone. So pretty good. Yeah. Ashish, who will be talking about how do we go in for accreditation. I think in today's era, every single solo practitioner is going in for this accreditation, whether it is the entry level or full accreditation. And there are a lot of advantages, and I feel everybody should go in for it. And let's hear it from Ashish.
Good morning, everybody. Now, after having a good biometry, starting our social media marketing, then opting for good IOLs, one more important thing in the business of eye care is accreditation. Now, accreditation advantage, should one go for it? The first question is that should we have accreditation? Now, National Accreditation Board for Hospitals and Healthcare Providers, that is NABH, and what is this and should we have it is what is my talk about. Now, this is a council, this is a constituent board of the Quality Council of India, which has been set up to establish and operate accreditation programs for healthcare. Now, as a hospital perspective, can we do without it? We are as it is providing good quality clinical care. Yes, we have to have it because this is very important for our survival. We cannot survive without accreditation. Why? Because there are a lot of public sector schemes like CGHS, ECHS, Haryana government, Ayushman Bharat. Now these have an undertones that you should have a NABH accreditation, then only your hospital will qualify for these empanelments. And howsoever good a doctor you may be the best phaco surgeon, but the patient is going to come to you if he feels that your hospital is empaneled and he does not have to pay for it. Besides, the insurance companies, though it is not mandatory, but they still say that you need to have NABH and they give a better pricing for it. So a cashless facility, as I already said, it is a must-have, otherwise the patients won't even enter your hospital. If you do not have an empanelment, you feel that, when I did not have CGHS, I used to think that there are no CGHS patients around. The moment I had CGHS, I realized that there's a good lot of patients who are CGHS empanelment and they give you a better, returns. So the advantages to the hospital is that the hospital is going to thrive after the NABH. you need to compete with the the market forces and the other hospitals, so you need to have these things. Besides, it also gives you an economic or financial advantage. There are places which give better pricing for NABH accreditation. Just a 15% increase, if you actually take that value to the 12 months and then full the whole budget of the year, you feel that this 15% increase is going to take care of your expenses for accreditation, and in fact you will save more. Now then again, for every advantage there is a big headache to have an NABH. There's a lot of paperwork, a lot of filings, registers, documentation, and I feel that all these quality improvement initiatives, you have to have it in your system. It should be the second thing in you, that these protocols have to be made, these manuals have to be made, these registers, the checklist. You have to train your staff so that all these documents are being done as regular protocols. So these unnecessary documentation, sometimes you feel that you are being harassed, you are being unnecessarily doing all these things. But yes, this is a blessing in disguise. In case anything goes wrong, in case you have an endophthalmitis or something goes wrong, the patient complains against you, then the court sees the paperwork. They see your file, how well it is documented, whether you've written everything, you've done a proper consent. So you become medical legally very strong. You can actually face any complication that you have done or has happened in your hospital if your documentation is good. And for this, I would say that NABH is a boon. Even the CMO, if he conducts an inquiry, he will be seeing how you are sterilizing your equipment, whether you are maintaining the registers, whether you are actually checking for your OT qualities, the laminar flow and all those things. So that time, the regular filling of these registers will give you a lot of satisfaction that you will be able to sail through. As a byproduct, I would say that you can take it as a marketing advantage. As Dr. Aanchal had said, that anything you have to actually feel from inside that what kind of unique selling thing that you can have. So this is also a selling proposition, that you have an NABH accreditation, so you are taking care of quality, and that is what will attract your patients. Then international recognition, you can use it as a tool for medical tourism. So this kind of logo, guarantee, quality guarantee. You can give a quality guarantee to your patients that, we will try and give you the best because we maintain the highest standards that the government and everybody wants. So all these kind of things is this. Then besides that, there's a training part of NABH, which is again very important. You are training your staff so that they do the things in the right way. So even in cases of fire emergencies, we all have these fire extinguishers and all this. We hardly used to take care whether we need to teach our people around to use them. But because of NABH, you are bound to give them training. You are bound to maintain the documents. So you feel that might as well do it. So it is a kind of a force that makes you come out of your inertia and do all those things which you used to ignore. So besides that, if we actually feel that the human error is minimized because you are actually writing down everything that you are doing, and you get community confidence, it's an opportunity to benchmark with the best. And if I feel about the government, they have to devise ways to actually check and recheck you guys, all of us. And whatever whatever government comes up with the compliances, it is all because we tend to ignore them and tend to not follow them. So advantage to the customer, the consumer is happy. He sees the hospital is decked up, the hospital, the staff is taking care of them. So patient is always the biggest beneficiary, and if the patient is happy, your practice is going to grow. So staff, then again, the efficiencies and competencies get improved. They are more happy because everything is well documented. Their personal files are made. We are taking care of their health care, their ESI, all because we have to do it because NABH wants us to do it. So my experience in NABH, I have 2 hospitals, and what we do, we started with a NABH entry level accreditation and moved on to the complete. We did hire a consultant initially, but then again after that we have never hired a consultant and we are managing it by ourselves. The most important thing is that the statutory compliances. Try to have those statutory compliances, and there are 10 chapters in the book. So it is like this book, you read it properly, you answer them properly, you have them documented, and you are going to pass this exam. You may have there is something called non-conformities. The moment they are going to come for an assessment, they are going to say that all these things are lacking. Don't worry, you take care of them, and they are going to pass you. You will get chances, and you will clear NABH accreditation almost 100%. So you obtain a copy of NABH standards, implement it by yourself for 3 months, and then fill the form for application. And once you fill the application, there is going to be a pre-assessment and then the final assessment. So what they are going to do is that they are going to do a proper sample requirements. They are going to visit all areas of your hospital. There will be proper staff patient interviews, files, statutory compliances, mock drills, and all these things. For these statutory compliances, this is something which we need to have. We should try and have an occupancy certificate. They just need a document. They do not want whether it is 2-story or 3-story, just a document. That is what thing that is needed. Then for fire, people are getting very, very stingy about it. You need to have a fire audit. A third-party audit also works nowadays. And you need to be slightly compliant with the law of the land. And the biomedical waste management is very easy to get. So there are all 10 chapters. Each chapter has some prerequisites which needs to be documented. The first 5 are patient-centered standards, and the second 5 are healthcare management standards. You try and tick mark all those things, and you are going to clear it. There are few quality audits, the clinical audits that you need to take care. Then there is something called, in case you do not have something, suppose you do not have a proper lab, you do not have a proper laundry service, all you need is an MOU. You have to have a proper MOU with the right persons, so that you can show that as per our protocol, we outsource these things to the particular lab or to the particular hospital to take care of our emergencies. And this is the written protocol, and this is written, and everybody knows it. So then they actually give you a benefit of doubt. The hospital is all decked up, the signages, the scope of work, the patient's rights and responsibilities, patient information. These the codes, the staff training has to be done, the code red, blue, pink, purple. This is a part of it, otherwise you'll have NCs in this. So finally, electronic medical records that Dr. Vinay is going to tell us. Sooner or later, you have to have it, so it helps in a lot of NABH tick marks that you can do, because once you have EMR, a lot of patient care standards are actually fulfilled by that. So accreditation cannot be ignored. It is a process that you have to enjoy and make use to your advantage. Try and train your staff so that it comes as a second nature to them, that this is a part of their job. They have to fill all these things. They have to maintain these registers, so that once the assessment comes up after every 1.5 years, and so you are ready for it. So take home is that it is easy. You just have to have few statutory compliances, some paperwork, but it is an exam that you are going to pass, come what may. Maybe with a supplementary, that's it. But if you apply for it, you are going to pass. So don't worry about it. Thank you.
And thank you, Ashish, for clearly highlighting that result exam का 100% ही होना है. थोड़े बहुत supplementary लगे. I think this is most important, because that is what the biggest scare is. And it's a lot of paperwork, but at the end of the day, you feel that you are giving your best to the patient and things are in place. So when you feel things are in place, that is what the goal is achieved.
In fact, Dr. Parul had just recently got NABH accredited, full NABH. And when we were talking about it, I was telling her that you are going to pass. And the fact that you are trying hard to, prepare for the exam, so that is more than enough. You have to pass, and she passed with flying colors. There was hardly any confirmed.
Thank you.
Sir, it is always better to give it to your staff, so that they keep on, as I said, it should be their second nature, that they need to fulfill all these registers and all those things. And obviously we need to block some hours for that, which is again, once you get the assessment, you become little lethargic, and then once the assessment comes again, then you start, preparing yourself. But I would say that it is better that we do it in the regular way. We do try to have one.
Can you please ask it on the mic?
Okay.
माइक दे देंगे, माइक दे दीजिए.
Okay. Sir, they may not even ask for it. You can go for an entry level first, NABH. They will be asking you about, if it's in a residential area, you should have an occupancy certificate for a residential area. You can have a third party audit for fire, which says that all these things are done for. That will also work. Biomedical waste management would not.
I have biomedical.
So if you apply for an entry level, I am sure you will be clearing it. No problems. They are not going to go into all those details for entry level. You just apply for it. Entry level is not so.
Entry level is what?
So there are two levels. One is an entry level NABH accreditation. The other is a full NABH accreditation.
Okay.
So you can go for entry level. Even in the residential area, it will pass.
Okay.
Even full NABH, I am realizing it. I was reading between the lines. Even that can be passed, because they are not very jittery about it. They need an occupancy certificate. You can try and maintain something like that.
But fire I'm not getting.
No, you don't need fire. You just where are you working, sir?
In Bombay.
Bombay. So then you can have a third party audit.
What is third party?
Third party audit is that there are certain fire agencies who are going to put up fire extinguishers and all at your place.
Okay.
And they are going to give you in writing that they have placed it and they have trained your staff, and that this place is fire compliant for a lot of things.
Okay.
So that document will work for you.
Okay.
So
But
we'll
legally I can practice without nursing home.
Sir, that the law of the land says, but then you are practicing it for quite some time.
Yes,
So nobody is saying anything. So
nobody.
even entry level NABH will also not say.
Okay.
So we'll have we are little short of time, so we'll have Dr. Vinay talk about the EMR and the TPA empanelment. Dr. Vinay works. He owns Synergy Eye Hospital, which is a very good model for practitioners who can use the facility. And I think this is one of the pilot project, I would say, in Delhi NCR, which Vinay has put up. So Vinay, we'll hear about the EMR and the TPA.
Yeah, so I think before that, we were talking about passing the exams, right? So when we were also medical students, हमारा ध्यान होता था, somehow we should pass the exams. And now we are reaping the benefits of passing those exams. So when you start with NABH, you are only bothered somehow you should get that bloody certificate. But once you have done that cycle a few times, I've done it already 3 times, we've been there for more than 9 years, then you start actually reaping the benefits out of it. So, you start with passing the exam, and then you start to top it up, and next time the counselor, the people will come and say, boss, this is extra that I'm doing beyond what you're supposed to do. So right now consider not passing the exam, but later you really reap the benefits of it. So that's the analogy that I'll say. So now coming to the talk that was assigned to me about EMR and TPA. So today the hospital industry is not a hospital industry anymore. It has become more of a hospitality industry. We can do our premium practice not only by putting the so-called premium IOLs. It is the premium services that the patients require. Now, IOL is a very, very small part of the overall experience that you're giving to the patient. So everything has to be taken care of for the patient. And of course, the quality is a given. Now, I was talking to someone. He says that never talk about quality. Don't talk about what you can show. So quality should be seen, not should be talked about. And going cashless and paperless is 2 ways in which you can make the patient's life easy. And that's how you can win their hearts and also make them open up their wallet for you. So I'll be talking about TPAs to begin with. So in an ideal world, we should not be having a cashless because there's so much of a pain that we have to take care of. Patients should pay, we are giving them a service, and they should get a reimbursement. But unfortunately, we are not living in that ideal world. It may not be a very practical solution. In fact, avoiding cashless may also mean less cash for us because as someone was saying, that people will tend to go to a place which is offering them a better service because there are so many options that the patients have. So better we adopt it early in our practice rather than someone else, your competitor adopts it and the patients run away from you. So what you need, So as Ashish was telling, we should be registered with the local health authority. That is very, very important. That is anyway important for us for the legal point of view. And to answer your question also, sir, I mean, we have been practicing for so many years with possibly without any legal licenses and all, but it's a good idea to know the law of the land, what is the norms that are to be followed, and if possible, we should try to follow those norms. So it's never too late to start to follow the norms, because if something goes wrong, then the people will come and they're going to look at the documents. When everything is going on right, no one bothers about it. You may be doing it from a basement of a dingy room. We used to operate in camps, we were operating all over the place, but now we're not allowed to operate in the camps. So better to follow the norms. And that again, if you're going in for a cashless, you have to make sure that your center is duly recognized by the local health authorities. The medical facilities are adequate. All the legal compliances are in place. Preferably QCI or NEBH is what they prefer. So there has to be some safety mechanism, some quality system should be there. And you need a dedicated staff to manage all the extra paperwork that is required, because as a professional, you would not be able to do all these things. So you someone to take care of empanelment, pre-authorization, billing, follow-up, etc., etc., etc. So it's a lot of work. The new scheme about cashless for all is there. So if you don't have a tie-up with a particular TPA, the IRDA has come out with this thing that if you inform them 48 hours or more so in advance, the insurance company is going to connect with you and you will have a agreement for that particular patient. Okay, for that particular patient, you are going to be given that much of amount. So you should have all the paperwork ready for that, so that whenever you are sending them, they'll be asking for some documents. So keep those documents ready with you and try to negotiate and get the better rates from the patients. So that's one thing. Some helpful tips is that you should have a well-defined tariff list. So that has to be shared with the TPAs on a regular basis. They often don't revise their list, but it's your job to, every time you revise the tariff list, send them a copy. So at least you have done your job of informing them. The accounting has to be preferably digital. And if EMR is a kind of a must for doing all the TPA works, though you can do for a small level, you can do without EMR. But as you grow bigger, you would definitely need them. And many of them prefer digital upload of the bills nowadays. So there's all online portals from which you can do that. A dedicated staff that I already talked about. You need an accountant to take care of making the right kind of bills for them and chasing them for the payments, to reconcile the payments and so many things. And sometimes the challenge we have is that if you're going for so-called premium lenses, they are not covered, then you have to make sure that you charge that extra from the patient with a proper documentation. There's an undertaking that you take from the patient saying that, okay, I'm paying this thing on my own volition, and I know that I would not get reimbursed for that. So all that paperwork has to be complete. Otherwise, you create a lot of challenges with the TPAs. So anything about the TPAs, if anyone has a question, because before I move on to the EMR. So the way I do at my place is I never promote upgradation. I say, okay, sir, you're authorized for this particular sum. We will put whatever package we have in that, and it's a decent enough lens. So there's no problem in that. Of course, your insurance companies has a tie-up. They are not going to pay more than that to us, and this is not a bad lens. If you want, that's an optional thing. I won't recommend it, but if you really want it, then as a favor, I can do it to you. But then you have to do this thing. So if you don't push it, the patients don't bother you as much. If you push it, that's when the patients start to bother you. Of course, that's a very, very gray zone that causes a lot of misunderstandings, but that's the way it is.
So then the problem is you are not able to promote the toric and the multifocals.
You should never promote the toric or multifocal. You should give them as an option, but you should never promote. The difference is promoting and giving it as an option. The moment you push it, you will be on the back foot. The patient is not happy with it, he's going to come and eat up your head. When the patient asks for it, then you are much safer. So I personally don't promote it, I give them as an option. Now you have to give it as an option because sometimes people will come back and say, you never told me about this. So an option has to be given. The pros and cons have to be told. I sometimes emphasize more on the cons than on the pros, because pros patients anyway know. And I want patient to ask for a multifocal or a premium twice from me. Yeah, toric I definitely promote because I say toric is a benefit, but multifocal or anything, I would ask patient to ask me twice, but again, that's my policy, how I push it. So if you push something, the patient will think that you are benefiting and the patient will grab. If the patient asks for it, you are going to be in a safer space. So that's my personal philosophy. So coming to yeah. Yes, sir.
I have not good experience with TPA. I was attached to the TPA. but-
Nobody has, sir. Honestly, nobody has. So as I said, ideally speaking, there should be a place where the patient pays us for the services and let him take the money from the insurance companies. But unfortunately, that is not the ideal situation. So we have to see how best we can manage that.
And sir,
But
just
they
one
never
question.
passed my paper. And when I phone call them, nobody is available, that officer. I stopped.
Sir, that is a norm.
I don't
there.
practice TPA nowadays. Just,
Perfect, sir. You're in Bombay. You're lucky. We all are envious of you people.
So I think most important thing, every doctor should unite. You know, we all should unite and stand
That's
against
not
these
going to
TPA
happen.
companies, which
That's
doesn't
not going to
happen. You know, so
That's not going to happen.
yeah.
Chalo.
So coming to the electronic medical records, now I think it's not something that we need to discuss anymore because that is a given now. I mean, if you are not in the beginning stage of seeing only 4 or 5 patients a day, there is no reason why you should not have an EMR. So electronic medical record is a must nowadays. So it's basically a collection of whatever patient's medical data in electronic format. It basically has demographic data of the patient, so that is very important. So you have got his name, age, sex, address, phone number, maybe his birthdays and other things. The histories in that, examination findings are all mentioned there, and for ophthalmology we are looking at a specified EMR because we have got a lot of parameters that we measure compared to the regular EMR that are available for the other specialities. If possible, a drawing tool is also very useful. So this is the kind of a drawing tool, the way I am right now drawing on the iPad, so you can always have a drawing tool, and these things can be linked up to the patient's file, so you can draw the retinal diagram, corneal diagrams, and all those things. So basically, you can either maintain the data in-house, or you can maintain it on the cloud. The cloud is nowadays preferred because the data is much safer there. The only downside of cloud is if the internet is down, the things kind of go kaput. But then as you can always have 2 internet connections, and someone told me that even the biggest of the banks are working on internet. And billions of dollars are being transacted on internet. If the internet is down, server is down, everything stops there also. So that's all right. We have to take that chance. But having it on the cloud is the better option. Other thing that you may do is the hybrid option where you can have it on the cloud and a small thing on your local server also. So you, even if the internet is down, you can still work. It can sync with the cloud later on. It connected to the computers, tablets, or mobiles on a network, and it can be accessed from various places by the different people. So different people will do their different entries, right? From the person who's giving the appointment to the person who's doing the registration, taking the payment, optometrist, your assistant doctor, you, counselors, everything can be interlinked. And it gives you the backup and retrieval of data. Now, what are the apprehensions that we used to have? What's the need to change? I think that part is gone now. I think we all agree that EMR is a must now. It is expensive. Yes, it is expensive in the short run. It is an expensive investment that you're going to be making, but in the long run, it's going to pay back multiple times of its value. A technical staff is definitely required to manage your systems. One person is good enough for that, but now most of your staff are very tech savvy. They have been working on the phone and tablet, so they can take care of all the things. Initially, it is a bit difficult to train the doctors. And doctors are more difficult to train than the staff because staff still is more malleable. The doctors are the ones who are used to our own scribbling, so you have to kind of push them. So in my center, I used to be using EMR because I'm blessed with a bad handwriting, so I had no option but to use an EMR. My partner was not using it, but when NABH came in, we had to adopt to the EMR. So I think that's also helps because the amount of writing that you have to do otherwise, there's no other option but to go for EMR. It slows down the workflow in the beginning, but the advantages are you give a printout as a prescription. It is more legible. You can add generic name to the medicines. You can give alternative names to the medicines, so that way it becomes much more legally compliant because the government will ask you're not going to be writing brand names, so you also write the generic name. You also mentioned that you can replace that with another brand also if you want. So all those things can be done on an EMR very easily. With hand, you cannot write everything, Ciplox eye drops, bracket ciprofloxacin 0.3% eye drops, that becomes a pain. So EMR, everything is all automated. It can be bilingual. It is much more impressive to give a printout to the patient and legally much more safer because you maintain a copy of a record. So this is very important. Important part about EMR, it should be the kind of EMR which should not be editable afterwards. Because if your EMR is editable afterwards, it has got no legal value. So you should not be able to edit it. And even if you are editing it, there should be edit record is available. That's important for the financial records as well as for the medical legal records. So this is also very important when you're making an EMR for yourself. The legal compliances and NABH cashless I've already talked about, minimizes the mistakes, minimizes the illegible handwriting. Possibly the jokes about doctors' handwritings would be of something of the past. So better patient satisfaction, much better, and better records retrieval. So patient comes to you, you have got the whole record with you. You can tell them, okay, last time you came on 24th of December last year, how have you been doing? Last time you had this thing. So by the time the patient enters your room, you have gone through his medical record very briefly. And when the patient comes, you start a conversation from where you left last time, 6 months back. So that really helps to build the rapport with the patient also. So in the long run, it does save a lot of your time. You don't have to go through all the papers because everything is there in front of your screen in a very well organized format. Unlike when the patient gives you all the prescriptions with the receipts and this and that, it's a messy affair. So on the whole, it saves much more time in the long run. You have a financial control, better patient engagement, patient education, patient retention can be better. You can use it as a research tool. So you have a predefined format, so therefore it is especially useful for the NABH where you've got all those multiple things to be written. Some of them are pretty useless ones, but yes, because it's an EMR, it's okay. You have to, for every patient you write, you have given an advice about nutrition. Now with the hand, you cannot write that, right? With the EMR, the thing can be just printed out there. So it's a huge time saver in the long run. And you can advise follow-up schedule to the patient. So whenever you're given the schedule, the patient gets a WhatsApp message 2 days before the next follow-up schedule. Patients are more likely to come back to you. That's where you get your revenues also from the patient. Patient also benefit because they're getting better follow-ups. Their disease management is getting better. You can integrate with WhatsApp and email as Achal was talking about. So that also works in your promotions as well. Now, HMS or hospital management system is a step above the EMR where you've got a comprehensive solution where appointment, billing, accounts, counseling, IPD, pharmacy, lab, patient engagement, CRM, all the audit compliances, everything is kind of taken care of in a hospital management system. Purchase, pharmacy, HR management, finance, revenue management. In fact, in my place, I've got about 25 doctors who are using my facility. So for every procedure, every patient seen, that doctor's name is recorded, what percent share that doctor is going to be getting for that. So they have a dashboard where they can see for every patient how much money are they getting paid. That adds a lot of transparency to the system. They also can see how many patients are credit patients which are pending. So they know these are the patients which are operated, how many days since the surgery, how much payment they have received, what is their share. So everything is very transparent. This is only possible if you've got an EMR. And waiting time on monitoring you can do with the patient, so you can improve the patient experience. And you can define the rights for the various users, so you can know who can do what all entries. So how to start is that you have to choose the right EMR for you. This is very important. And a single practice with a OPD of 15 to 20 can go with a simple EMR. But if you've got a bigger setup, you should go for a hospital management system or EMR which has got an option of upgrade. The vendor should give a good service. Service is very important, so don't just go by the cheapest guy. Go with someone who's going to be giving you good service in the long term. Don't do any customization initially. Initially, just go with whatever the EMR is offering you. Tweak your systems initially. Once you're comfortable with the EMR, then you should go for the customization later on. Once you understand the systems better, once you know what exactly you want. Otherwise, you will be in a mess if you try to customize it right there and then, right? And as I say, selecting the EMR is like a marriage. You should be very careful which one you select because the divorce is very messy. Because if you go from one to the other, all your data gets lost. So you have to be very careful whom you select. Don't go for the cheapest one. Go for the one that suits you best and who's going to give you the better service, which is compatible with you. Initially, don't give up on the paper because the things will crash. You would make mistakes. So have a backup of a paper initially. Till you get confident, then you stop paper altogether. Make sure you have got a well-defined backup system in place because the things, if anything can go wrong, it will. So you have to have a good backup system because once you are totally reliant on that, you have to take a backup in place. Train the doctors and staff, reward them for adaptation, and start slow. Don't use everything on the EMR at the beginning, but then slowly you can start building up from there. So this is what I've done. I think we are short of time. So I've just integrated the EMR with the WhatsApp appointments and everything. The patients get automated messages. Then they get the locations. Pre-operatively, they get all the information about what all they have to supposed to do. If they put on a disease, they can get the information of the disease on the WhatsApp. So everything we have done a integration. So this is my phone number here. If you can just send a WhatsApp of hi, you will see how the whole automation of WhatsApp will work. So you can just take a demo of that or visit my website. You can just click on the WhatsApp, just send a single message, hi, there's a whole loop of messages that will running through. So that's where the patient engagement also helps. When the patient is sitting in your OPD, he's going through some literature of yours. So that's where it helps. You can also make an app that we have made for the EMR link so patient can see their own previous prescriptions, next appointment, they can book their appointments, everything can be taken care from that. So I think this is where I end. So after talking about making it cashless and paperless, there's another thing that we can talk about is how to make your growth effortless. So I'm basically writing a book which is Beyond Vision, how we can improve our growth by increasing patient loyalty. So these are some of the chapters that I've written. It's going to be coming in a month or two. So patients will chase you only if you don't chase them. Yeah, okay, fine. So thank you. If there are any questions, I would be happy to answer. Sir. No, it's not that it's not acceptable. It is acceptable, it's much more tedious. So if you have a patient base of more than say 10, 15 OPD in a day, I think it's sooner or later you must go to a EMR system, because that is the amount of legal compliances are required. It's much better to retrieve the data from there. Your prescriptions are going to be much more legible, much more in line with what the requirements are. So that's what.
Do we have speakers from the next session, please? I think, yeah, so we can have discussion later. So we'll thank you all the panelists, Dr. Ashish, Dr. Vinay, and Dr. Deepa, and thank you the audience.
Thank you, Dr. Mukesh.